Thank you, Kelsey, and good morning, everyone. It's my pleasure to open the day two of our conference, which really follows a wonderful first day, which was focused. The entire conference is focused on building bridges. So, yesterday was all about building bridges between the clinics and the community, and also between research and practice, which is, as I was saying towards the end of the day yesterday, it's a bi-directional bridge between what we learn in research and apply it to practice, and what we learn in practice and apply to research. And there were great examples of both kinds yesterday with Emily Klein starting her experience from the community of primary care and what we can learn in terms of intervention approaches. Now, what she found was in some ways good news, a kind of a nice, pleasant news to understand, and that is that in primary care and in pediatric settings in particular that she was describing, not all that looks like psychosis ends up being a serious psychotic illness down the road. So, which is good news. A lot of them get better, and then many of them just reassurance may be sufficient and close watch. And some others, of course, we have to pay more attention and follow up and intervene. But today is going to be a bridge of a different kind, and that is, um, what do we do when the results from research are not exactly very convenient, and how do we redefine what we do and make it better and successful down the road? And so we will start with that kind of an angle as our first panel session, followed by other wonderful presentations you will hear and panel discussions as well. So the um, the inconvenient truth, if you will, that I was mentioned that comes from research is the fact that when early intervention is implemented, of course, we have seen throughout the world through several um, controlled trials of early psychosis intervention versus standard treatment or treatment as usual, there are improved outcomes in the shorter run, no question about it. There are meta analyses showing that people are not only feeling better, but also doing better, and their quality of life improves. However, what happens in the longer run, 5, 10, 20 years down the road? The results are somewhat sobering and mixed, which might have lessons for us as to how to think about the future of early intervention in psychosis. So, we put together a panel of experts today who kind of bring expertise from different angles on that question. Um, we have Dost Onger, who is a professor of psychiatry, our own Harvard Medical School, and he is the leader of the LEAP program. He will be on the panel. Merita Nordentoft, who is a leader in early intervention in psychosis from Denmark, who has published some of the longest running follow-up studies of early psychosis intervention. And Eric Chen, who is currently in Melbourne but did his really seminal work in Hong Kong going back a couple of decades. Unfortunately, he could not be here today because of some family reasons, but he was kind enough to send us a um, videotape recording of his presentation, which is about 15 minutes. For all of the panelists, I asked the following three questions, and they will each of them address them from their own experience and their own vantage points. Question number one: Does early psychosis intervention results or effects sustain over time? Are the results durable? That's question number one. Question number two is, what psychological or neurobiological processes, if we intervene, might be the ones that determine outcome trajectories in the longer run? Yeah, that's number two. And number three, how should we be thinking about adapting or improvising our approaches to early intervention with that kind of knowledge going forward? What should EI look like in the years and decades to come? So these are the three questions that I would like to be posing to each of the presenters, and Eric has already answered those questions. We will have his 15 minutes at the beginning, and then that will set the stage for Dr. Onger and Dr. Nordentoft to present their particular viewpoints. I would suggest that, given that this is a 1 hour event, and we may already be slightly running late, each of you take between 12 to 15 minutes, Eric included, and then maybe we'll have time for about 10 to 15 minutes of a discussion. So with that, Elsie, could you put the first videotape with Professor Eric Chen on?
Well, thank you for inviting me to share some data and thoughts about early psychosis programs in the present and in the future. I'm Eric Chen. I'm going to share some data from the Hong Kong early psychosis program. So let me share the slides first. Yeah, okay. Okay, so I'm going to respond to the three questions that the chairman raised about early psychosis work. So first of all, does the early intervention effect last? So I'm going to refer to the program and the data from Hong Kong to address this question. Now, the data come from a cohort study comparing patients who received the early intervention program for 3 years with those that did not receive the program because they become unwell before the launch of the program. So it's a very close in time, but it's a historical control. They were matched in terms of diagnosis and pre-morbid functioning. And we're looking at the 10-year outcome data. Notice that after the initial 2 to 3 years, everybody received standard care, which in Hong Kong is a relatively low mental health resource service setting. Now, we have observed and has been reported in a few observations. So the functional outcome shows an effect that has been sustained over the 10 years. So cluster analysis review 4 outcome patterns over time. One is a sustained improvement. The other is sustained non-improvement. And there is one in which there is improvement in the initial years, followed by a drop after the early intervention years. So the blue line represents early intervention group. So there is an overall increase in the proportion of early intervention patients falling into the good outcome over time group. There are a few patients who had a better outcome in the initial years, but the outcome dropped subsequent to the stopping the early intervention program. And there are fewer patients who are in the non-response poor outcome all the way through groups. So it shows the effects of early intervention program in moving more patients into the sustained better outcome, functional outcome group. Now, a second outcome that has shown sustained improvement is the reduction in suicide. So comparing with the control group, early intervention actually reduced the number of suicides in the initial 3 years. And this difference was maintained in the subsequent years. So there was no catch-up of suicide after the withdrawal of the early intervention program. So the second question is, are there some biological or psychosocial processes that, if addressed early, may set long-term trajectories? I'm going to look at the two key outcome dimensions. One is about positive symptoms in relapse and refractory psychosis, and the second is about functional and cognitive outcome. And I'm going to be very brief. Now, first of all, in our other long-term RCT study, we compare maintenance versus discontinuation or tapering of antipsychotic medication. In year 2, after having maintained the medication for the first year, and the patients with better outcome, that is not having had a relapse in the first year and have no significant withdrawal, positive residual symptoms, psychotic symptoms, were randomized into either maintenance treatment for the second year or tapering and withdrawal of medication for the second year. After the second year, everybody have standard care, and the double-blind condition no longer sort of maintained. So people are free to change their maintenance strategy after that. So what we look at is outcome 10 years later. Now, we also compared the outcome with a group of patients who didn't do so well after the first year. And as a result of that, they were not being able to enter into the RCT studies. So there are 3 groups for comparisons. So this shows, if you look at the yellow, the orange bars, this shows the proportion of patients who are in not so good outcome. They're either treatment refractory or have committed suicide. That is a proportion of the sort of worst outcome. Now, on the left-hand side was the comparison between the 2 randomized groups that initially did well after the first year. You see that discontinuation of the maintenance treatment in the second year actually resulted in more people in that category becoming treatment resistant or had a suicide outcome at 10 years. So that this proportion is no longer significantly different from those that initially started off not so well, so that they couldn't enter into the RCT study. That is, they already have a relapse or residual psychotic symptoms after the first year. So maintenance medication can actually protect people who did really well initially from relapse, and the protection from relapse also protect patients from developing a treatment refractory stage. So this shows the initiation of clozapine. The red is the group that had discontinuation and tapering. So many of those actually in a group that developed a need for clozapine in the 2 to 4 years time frame after the initial discontinuation study. And these data are consistent with a large-scale population study from Finland, also showing the tendency of after relapses, psychotic episodes become more difficult to treat with the emergence of increasing treatment refractory states. So we look at potential underlying processes, and many groups are looking into this. But one very obvious low-hanging fruit is that could it be just a memory effect? Now, we're not talking about psychological, necessarily only a psychological memory of the psychotic experience, but we are actually talking about memory left in the brain as a result of the increased dopaminergic stage, which is facilitating neuroplasticity in all the memory system, implicit memory system, autobiographical memory system, semantic memory, and emotional memory systems. So this postulate that during psychosis, increase in neuroplasticity encoding the information that was encountered during psychosis, and whether that would result in a more likelihood of relapse is something which is demanding urgent investigation. So we summarize this framework in a review paper published this year, so you can refer to this. And the idea is that with relapses, there is accumulation of memory which belongs to, which is based on synapse formation and belongs to a non-dopaminergic mechanisms that may contribute to psychosis. So, so with the accumulation of memory factors, future relapse episodes would require less disruption in dopamine abnormality, and therefore will become less responsive to antipsychotics, which are dopamine regulating agents. And this depicts a possibility of the different fates of memory. So on here is a well-integrated memory of the psychosis, well-integrated with the rest of the personal autobiographical memory that will enable this memory to be more accessible after recovery, so that future normalizing experiences may gradually influence and override the spurious associations that were formed during the psychotic state. Whereas memory that were poorly integrated and accumulated over relapse periods will remain segregated and may not be accessible for normalization. So switching to another aspect, we all know that exercise, aerobic exercise, have a positive effect on cognitive function as well as on mood and psychotic symptoms in various mental health conditions. And this is obviously also true in psychosis. And it is a study we have carried out now using mind-body exercise, yoga, and comparing it with aerobic exercise and control, showing that both mind-body exercise and aerobic exercce improve cognition very significantly. And these are all different memory parameters, but attention also improve in the yoga intervention. As a result, we design community exercise intervention programs for patients and their carers. And programs were also integrated with anti-stigma programs with visit and participation of school students who do the yoga exercises with patients, and realize that on recovery, patients are exactly the same as other people, and which is something they found amazing, because up till then, their exposure to psychosis patients were only from news and movies. And so another aspect of exercise, apart from improvement in cognition and also being good in anti-stigma campaign, is the communication of the message of agency. So a lot of the time people assume that brain changes and genetic factors in psychosis imply that the patient is passive and nothing can be done to determine the long-term outcome. But exercise is a good example in which the choice of doing something active and ability to do it over time can actually change structurally and functionally, brain anatomy as well as cognitive function. So that was something which is highly encouraged in our program. So what should the future early intervention program looks like? So following a little bit from the previous slides, early intervention programs are located in a strategic points early in the patient's illness journey, and it will always remain in that position no matter what the content of interventions are. So being there in the early stage in the journey, early psychosis program has a responsibility to carry out and to implement the best possible intervention for those critical years in the early phase of the psychosis. Therefore, it has the duty to innovate and integrate research and bringing the best possible outcome in a continuous in continuous cycles of innovation, evaluation, and further innovation and further evaluation. So integration of research in an agile system is important for early psychosis programs. And as many programs are already doing now, the staging and specification of clinical pathways are important. So these enable us to map out in more detail the different duration and care pathways, so that we can have more homogeneous samples during research to identify the modifiable factors that can improve outcome on a particular pathway, and that will facilitate research. Now, lastly, a coherent framework to inform the different components of the clinical process, such as using the memory model as an example, the reduction of spurious or stage-based memory formation by early intervention, thorough treatment of the psychosis in the early in the first episode, followed by facilitation of good integration of the memory. And this could be achieved by good peer programs facilitating meaning making and storytelling of patients recovering from psychosis. And with a good integration, then subsequent normalization of that memory can happen by good exposure to a wide range of experiences in rehabilitation programs, and also facilitation of experiences of new activities and new learnings, and avoidance of things that will inhibit learning, like depressive episodes or over-medication with antipsychotic medication. So this is an example of what might be a good early intervention model for the future. So I've highlighted in these slides the key principles in an ideal future early intervention model, and I would really appreciate your feedback and discussion on these topics. Thank you so much.
Thank you very much, Dr. Chan. That was a beautiful set of responses to my 3 questions. So let's see if the other panelists would have a response to the same 3 questions. I'll request Dr. Nordentoft to present her viewpoint.
Yeah, but thank you for inviting me. And should I give my presentation now?
Can you? Yeah.
Yeah, then I hope that my slides can be presented as I sent them already.
Did we get your slides, Kelsey?
Yes.
You can
Yes,
share it.
I have them, or if you are able to share, you're welcome to do that too.
Okay. I'd be glad to hear that. But thank you for posing those very interesting questions, and I'm going to reply all 3 of them. First,
So, Merata, could you speak up a little bit?
Yes. I'll be happy to give my presentation. I hope I can answer all 3 questions. I hope that I can have my slides on now.
Kelsey, you may want to share them.
Yeah. But I can start.
Yeah.
Can now she start? Yeah.
Great.
First, before I answer the first question, I would like to share just some very encouraging news from Denmark. But of course, I will answer also to sustaining the benefits of early intervention after first episode psychosis. Next slide, please. We've had this situation in Denmark that there's been a lot of investments, and it's actually maybe more than 20% that the overall budget for psychiatry has been increased with. So we have worked a lot to achieve that, but now we have actually had a plan endorsed by the all parties in the parliament. Next, please. And it was a long process where we did a lot of work. One thing we did was to send a budget to the parliament, asking them to provide 4.5 billion Danish crowns for psychiatry, and they actually ended up in doing that. If I can take this. Okay, next slide, please. Does it help? I'm speaking right into the microphone now.
But I'm still getting requests for you to speak a bit louder or increase your
Is this more helpful?
amplifier.
Yep.
Okay, I try that. This is just a picture of the entire parliament when they decided to finance the 10-year plan for psychiatry. Next, please. And what they decided was that they wanted to give more capacity to assertive outreach, Opus, the early intervention service, but also services for people with more chronic conditions. And they had also support for outreach team for homeless people and an acute professional helpline and national plan for suicide prevention. In that way, we are in a very fortunate position. Next, please. And as Kesh already mentioned, there's a very solid evidence that early intervention services have at least short-term benefits, symptom reduction, functional outcomes, and quality of life. We've seen that in several review papers. Next, please. This one is one of the most famous ones. It was published in JAMA Psychiatry in 2018, a meta-analysis of early intervention services. Next slide, please. It showed convincing evidence of effect on all 15 outcome measures. It was a meta-analysis of 10 randomized clinical trials. So it documented the short-term effect. Next slide, please. Also in the Cochrane Institute, we could see that there were effects on, again, short time, but on recovery and of the ability to prevent disengagement from services. Next, please. And also the European guidelines summarized the evidence regarding negative symptoms, so that they concluded that there's evidence that early intervention services can improve negative symptoms. Next slide, please. So we did the Opus trial, which many of you would have heard of, and we have had now a 20-year follow-up. We randomized 547 patients into 2 different groups, and half of them got intensive Opus treatment for 2 years, and the other half got standard treatment, which was much less intensive. Next slide, please. And here we have the main results of the trial. We showed that there were short-term effects on psychotic and negative symptoms. That's where the arrows point. On one hand, the orange line is the negative symptoms in Opus, and the black line is the psychotic symptoms in Opus. But what you can see is that it is not long-lasting. After 5 years and 10 years and 20 years, we cannot see any effect any longer. Next slide, please. But there were some sustainable effects, and this is an effect on ability to stay in independent housing. Here we have looked at how many days in supported housing facilities do people spend from the 2 groups in a 10-year follow-up. And we could see that it actually made people more available to stay out of supported housing facilities. Next slide, please. We could also see that people spent less days in hospital. This is the 5-year follow-up, where you can see the blue part of the bars are days in hospital, and the pink part is days in supported housing. Next slide, please. So we could try to convince the politicians that they could actually save money because it was cheaper. Next slide, please. So we could conclude that there's strong evidence for positive effects, and it's cheaper than better than standard care. So we recommend that it should be implemented to improve the lives of young people with psychosis. Next slide, please. So we also did a study like the one in Hong Kong, where we tried to find out whether we could maintain the positive results of specialized early assertive intervention. We called it the Opus 2 trial. Next slide, please. Here we randomized 400 patients into two groups, and one group got early intervention services for 5 years, and the other group got treatment as usual. But as part of the treatment as usual, 20% got actually a intensive treatment with assertive outreach. Next slide, please. So what we could conclude from this trial was that both treatment could maintain effect on negative and psychotic symptoms, but patients preferred 5-year treatment of Opus, and there were fewer patients who dropped out of care in 5 years of Opus. Next slide, please. Here you can see that there was a better working alliance and a better client satisfaction in the Opus group compared to the treatment as usual group. So extending treatment after 2 years had some positive effects. Next slide, please. And we could also see that there were fewer dropouts in specialized treatment in the 5-year follow-up for those patients who had early intervention services for 5 years. Next slide, please. So we could conclude that it's possible to maintain positive clinical effects of early intervention services by extending the services or by a stepped care program. Next slide, please. So, and next slide. We have disseminated Opus all over Denmark. That's just to demonstrate that. Yes, next slide, please. And then we asked ourselves whether the positive results could be expected and sustained also when the experimental treatment became standard care, because now Opus is standard care all over the country. And you can see on these two important measures, also the implemented treatment is better than standard care. And that's the Opus real world. That's the results of what happens when Opus is implemented as standard care. And you can see the mortality is lower. And you can also see that the risk of psychiatric hospitalization is lower. So it is possible by implementing the treatment to have better long-term results. And next. So there are long-term effects of early intervention services, and they can be sustained when early intervention services are implemented as standard care. Next slide, please. Yeah, it's just a boast. It's just that the patients were also satisfied with the treatment, and this is a sign made of pearls that one of the patients made. Next slide, please. So we have identified some challenges. Next slide, please. And one is post-Opus anger, and it is especially the relatives. When the patients are transferred to standard treatment, they experience that they get much less involvement of relatives, and they also get much less intensive treatment. So the relatives, and also in some cases the patients, get angry. And the other one, next slide, please. And we need more studies on how to maintain positive effects. Next slide, please. And it's not only symptoms. We will also have to look at everyday life. We just have some results where we saw that after 20 years, 40% of the patients had a GAF score, Global Assessment of Functioning, of only 40. So it's not just about psychotic symptoms, it's also about functioning in everyday life. Next slide, please. Yeah, here you can see that the psychotic symptom trajectory are actually pretty good. You can see that the early remission trajectory is 51% who experience early remission of psychotic symptoms, and it stays like that. And there's also stable remission and intermittent symptoms, which ends up in a very good with very good results. And those who have continuous severe symptoms or relapse with moderate symptoms, it's only 20%. So we can, regarding the psychotic symptoms, I think we have a pretty good track record. Next slide, please. But we know that there are some people who experience hallucinations, and we saw that it was 25% of the original cohort that after 10 years still had a lot of auditory hallucinations. Next slide, please. And as you might know, as clinicians, the voices they hear, they are not pleasant. They could be aggressive. They could be commands against oneself, commands against others, and it also could be derogatory or threats or interfering with treatment. A lot of negative statements. Next slide, please. So we have developed, we have replicated the AVATAR trial from the UK, where we create a visual presentation of the voice the patient hear, and we also create an auditory presentation of the voice the patient hear, and we try to support them in coping with the voices. So next slide. The voice could, for instance, say, cut yourself with a razor blade, or I will kill your sister. And then next slide. We hope that the patient will be able to say, I'm stronger now, I don't have to obey you. And then the therapist also has a role to play. Next slide. She says, well done, you are much stronger now. So that's the kind of trialogue we are trying to facilitate. We've done that in a large randomized clinical trial. Next slide, please. And here you can see the results that we are able to reduce the influence of voices, the frequency and the distress with auditory hallucinations. So we were very happy to see that we could actually replicate what was found in UK, but this time in a larger sample. Next slide, please. Yeah, this is just about saying thank you to all the collaborators. Next slide. And all the funders. And next slide. All the people involved in the studies. And next slide. All the people we have collaborated with all around the world who have supported us and inspired us. And next slide. It's just all the patients. Also, a thank you to all the patients who took part in this. So I hope I've answered some of your questions. If I think of which mechanisms could we hope for, biological mechanisms, which mechanisms could we hope for? I think the fact that we could actually reduce substance abuse could have a long-lasting effect, and also a biological mediated effect. And also what Eric Chen talked about, if we can reduce the length of time, the duration of time with psychotic symptoms, that can also be something that can where we can have hope for a better outcome. Thank you.
Dost, feel free to start here. Yeah.
Yep, I'll go ahead. Thank you. Thank you, Kesh. So, hi, everybody. I see my role in this panel really as a commentator, because we have not done the kinds of long-term follow-up studies in our research group, as you just heard from Dr. Chen and Dr. Nordentoft. They really are the global leaders in this kind of work. So I think you already heard some very interesting presentations. So what I'd like to do instead is to provide a little bit of the context and look into the future about what lessons can we learn from where we are in this literature right now. My own background is more in the neurobiology research and psychosis, so actually that's where I want to start. But before I do that, I also want to just say I have visited Denmark, and I visited the Opus clinics with Professor Nordentoft, and these are good places to work. The clinicians want to come to work. The patients want to come receive care there. As you heard, there is this post-Opus anger. And I think that's actually really relevant. I'm going to come back to this about what kind of services should we be providing people, because I think we can learn from that. And that hasn't been easy to replicate, I think, in the rest of the world. It's just every country is different, every culture is different, but there are certain things about this Opus network of clinics in Denmark that really create a different feeling. So why are we interested and excited about early detection and intervention? Starting from a neurobiological point of view, I think there's been good evidence for both a neurodevelopmental and also a neurodegenerative aspect to psychotic disorders, major mental illnesses like schizophrenia, bipolar disorder, and related conditions. On the neurodevelopmental side, we know that many of the risk factors for developing psychotic disorders are developmental. So they have to do with how the brain, both brain development and psychological development, how the brain is developing even in utero when the baby's brain is growing in the mother's belly, and then during birth and early childhood. If there are insults to the developing brain that can take the brain off of its normal trajectory, that can increase the risk of developing schizophrenia, bipolar disorder, and related conditions later. Also during adolescence, childhood and adolescence, things like trauma and neglect and bullying and various other kinds of social exclusion can actually increase the risk of developing a major mental illness as well. So these are things that make you think, so if the brain has a more normal trajectory and now you have an individual whose trajectory is coming off of that normal curve, then that's a problem, that's a risk. On the other side, once the diagnosis has been made, we know that the brain continues to evolve and change, and there's a lot of evidence that suggests that there are progressive brain abnormalities in the early years and even into the more chronic years of a psychotic illness. The cerebral cortex covering our brains can actually shrink. White matter can actually show more abnormalities. The ventricles in the middle of the brain start to enlarge, and those are filled with fluid, so it's not brain tissue. So you're losing brain tissue and you're enlarging your fluid-filled ventricles and so on. So because of both of these reasons, the developmental and the degenerative aspects of psychotic disorders, the notion of early detection and intervention is really attractive. It's alluring because the idea is if you can identify people who are at risk and as they're developing the illness, and you can do something to change their trajectory so they go back on a more normal trajectory and prevent both the developmental and the decline, the degeneration afterwards, that should give us much better outcomes. That's why there has been such excitement about this in the field. And as you saw from the presentations, we already have strong evidence that this is true. If you can actually intervene early, you can actually change and improve the symptoms and improve the outcomes for our patients. And that's why we are here. That's why MassSTEP is here. And it's just been great, inspiration to see the field evolving in this direction. But the challenge we face now is what you heard from both Hong Kong and Denmark, that long-term outcomes actually are not that easy to improve. In other words, what we're seeing is that if young people are receiving care early on in their illness for those 2 years or even 5 years, their outcomes are improved during that time. But then, of course, at some point, if you stop that early intervention and you come back 20 years later, you're not seeing that those young people are in much better shape. A lot of the outcomes actually start to look more like the outcomes of people who didn't receive that early intervention. So, if I had this mental image once of, with cancer, you can see this sometimes. For example, early stage melanoma. If you have somebody with a skin lesion and it's potentially dangerous and even life-threatening and deadly. But if you discover that melanoma early on, you can just have a simple office procedure where you remove the melanoma and it's gone and you don't have a problem anymore and you've saved a life. That's the kind of early intervention that I think we have sometimes as a mental image that we would like to do. But the reality is it's not that easy. And of course, it's not that easy in most of cancer. Melanoma maybe is a special example. In many cases, even with early detection and intervention in cancer, in Alzheimer's disease, and other fields of medicine as well, what you're doing is you're improving outcomes, but it's not a simple thing where you just simply bring somebody back to a healthy trajectory and everything's going to be fine. So what we're discovering is that early detection and intervention can really improve things, but in the long term, we still need to be thinking of how to improve outcomes in the long term. So how do we do that? Looking into the future, Dr. Keshavan asked this question about what should the early intervention of the future look like. I think what we need to be doing is offering people, young people, interventions that they feel fits with their agenda. Offer them places that they want to come to. Offer them support that makes them feel welcome and understood and makes them trust that the system, the mental health care system, has their best interest in mind. Because that's the kind of relationship that will actually ensure that in the long term, they feel like they're taken care of and their needs are being met so that they can then feel strong enough to turn around and go out into society and improve their own outcomes themselves. Because ultimately, treatment is really only one leg of that stool, and what you really need is the individual who is empowered to have a better life and do things that they want to do, and that's actually what's going to keep them well. And then the third leg of that stool probably is society. You know, there is a treatment, there is individual and society, improving our understanding, welcoming people with psychiatric disorders, supporting them, reducing stigma in ways that actually improve long-term outcomes for our patients as well. So I want to keep it short because I know there's also questions, and we heard from we heard two great presentations. Mine is mostly to provide this context about where we are now with early detection and intervention. It's not going to be as simple as an office procedure. You know, you come to a clinic for 2 years and then you don't have to do anything else. And 20 years later, things are going to be good for you. That's not really what's happening. What we really need to be figuring out is, okay, the early intervention is the beginning of the story, but we now know that it's not going to take just those couple of years and then everything's going to be fine. What we need to be thinking about is creating treatment systems that actually improve outcomes for the long term. And that takes money, that takes vision, that takes leadership, takes optimism. And that's why I mentioned the Opus clinics at first, because I think, if we can create these welcoming places where people want to come, that's actually going to improve outcomes just as much as the medication or the details of the psychotherapy. Of course, those are important, but that's not the whole story. Okay, let me stop there because I think there will be some interesting discussion as well.
Yeah, thank you, Dostat, for really succinctly summarizing the state of the field. To me, one quote from my friend Ashok Malla, which I'll slightly modify, sums it all, which is, he said, early intervention is more than just intervening early. I added the word just because, intervening early is good, but we need to be doing a lot more. Maybe intervening early and in the longer run as well. And, sustaining the intervention, because give up early and you may end up going back to the table. That also brings us to the other major point that Eric Chen made about the changes in biology that set in after the first episode. And he pointed out, which is very, very insightful, that it is not the psychosis alone, but it is the state of the brain and mind that carries that memory, long-term memory of the psychosis in biological terms. In other words, does psychosis leave some kind of a scar that is, very vulnerable to further irritations and worsening with subsequent stresses in life? This is an idea that has its roots from previous literature as well. Jeff Lieberman, many years ago, argued that what might underlie the persistence and recurrence of psychosis may be due to a hypersensitization of the dopaminergic receptors. So that again is a reflection of what you might call pathological neuroplasticity. The brain learns to wrongly see everything as equally stressful. It's like PTSD in a way, biologically. So that's an intriguing idea, which raises the question as to whether introduction early of trauma-based interventions might be so critical. Even consider psychosis itself as a trauma and maximize efforts to help the person integrate psychosis into one's life, normalizing it, and then have adaptive expansion of other aspects of one's self, and use all the tools that we have, like exercise and yoga, to build the brain to compensate into normal adaptive neural networks. So I won't go into too much more myself because we want to give some time for other comments from the audience. I want to hear, if possible, a brief comment by Rajiv Tandon, who also has joined. He's a leader in the field as well, and then others as well. Rajiv, you may want to get the last word. So, but before him,
Thanks, Kesh.
other comments. Yeah,
I'm going to try and leave time because there are lots of questions as well.
yeah.
Great presentation. And, I want to just thank Dost and Mirete, for outstanding presentations. And Dr. Keshwan and I have been organizing a 4-year series on reimagining schizophrenia. And Dost, you've been part of it. Mirete, you were almost part of it. Helen Hansen did an outstanding job in Rome. And we had actually just a month ago, we had a colloquium on early intervention and disease modification in schizophrenia, which in some ways touches upon this. And there are just 2 points I'd like to, briefly make. The first is, as we think about brain processes, relevant to expression of psychosis, it's really important to think about the brain is not a fixed structure. It's a changing structure in the context of aging. And so, and that interacts with individualized risk factors, which are different, which is why we see heterogeneous outcomes in individuals. And that's a consideration that we must have as we think about the questions that you asked. Does early intervention, are the effects sustained? Well, some effects are sustained, some effects are not, but it's certainly important, which points out that early intervention, the earlier the better. It has to be individualized, it has to be targeted, it has to be maintained. What has to be maintained is something that one needs to think through, because the same interventions that were effective and important earlier on might have to be modified in the later stages of the illness, because it's an evolving brain, it's a changing brain. And so what you need to target might differ. And I think information from Opus, Epic, etc., will really inform us in that regard. A second thing that I would say is, we ongoing treatment, individualized, targeted treatment, much more than medication. Medications are necessary, but not sufficient. And I think that's a really important thing to keep in mind. And the last thing I would say is, it's important to think about early intervention as being very important. The fact that it's not enough, at least the way we've conceptualized it, and some things have to be ongoing and maintained, does not mean it's unimportant. It's extremely important. It does make a difference in the lives of individuals. And so, fact, and I mean, is another example of something that's really important. And this was something that, Eric pointed out, and Miretti pointed out, that those are the services that are being supported by the Danish budget. So I'll stop there because I know there are lots of other interesting comments and questions.
Yeah, thank you, Rajiv. So we have time for maybe 2 or 3 questions from the audience or comments.
We have one question in the chat. Can you discuss the current view of both speakers on whether medication should or should not be withdrawn after 1 to 2 years of no symptoms? And are there any predictors of whom this could be done with?
Mahita, go ahead.
Yeah, well,
that was my question.
yeah,
First, I think the most important thing to these young people is, when can I come off this medication? And according to Eric's data, it looks like we really shouldn't take them off. Am I right? Or maybe Eric could clarify this.
I think if we look at it on a group level, we shouldn't take them off. That's also what the meta-analysis shows. But on the other hand, there are some people who are successful. Even though there's an increased risk by getting off medication, it does not mean that everybody will have a relapse, even though there's an increased risk. It is a little bit like lung cancer. Of course, we know that cigarettes increase the risk of lung cancer, but not everybody will get it. So I think we will have to recognize that there are some people who can actually get off medication. And in Denmark, we can look at the long-term data with prescription. and we can see that 40% of the patients do not take the medication in the long run, and not all of them get psychotic. So what I would recommend is that they all want to try, and I don't blame them. So we could have a process where we could try if it's possible, and I think what will happen then is that some will realize that it's not possible, and they will be more likely to accept that they should continue with the medication. And then there'll be some who actually can do without medication. For them, it will be a relief that they will get rid of the side effects. But overall, we know that medication reduces the chances of relapse, but it's not mandatory that you get a relapse if you de-prescribe.
Yeah,
Yeah.
I totally agree with that summary. I think the big point is about the heterogeneity of the first episode population. There are lots of people in this first episode population, whether we want it or not, they're just going to stop care, they're going to stop medications, and they're going to be fine. So, but we don't know who they are at the outset, and everybody tries. And the people who are good outcome patients, maybe they don't meet criteria for schizophrenia or schizoaffective disorder and so on. They had a psychotic episode, but they actually have a good long-term prognosis. So those people often try to come off of the meds, and sometimes successfully. So we really have to respect that. Even though we know at the average patient level, the analyses say they shouldn't come off of the medication. Some people actually are not going to need them long term.
Well, I would like to add to that point that yes, we do not know who might need long term and who might not. And maybe the major goal in the field is to find out who are the ones that might need a long term maintenance and who may be safely taken off. And perhaps we need to understand the biomarkers of relapse. And Eric Chen's presentation may be giving an idea as to what might be the biomarkers. Who are the people that develop aberrant salience that can be measured at a neural circuitry level, and those that get triggered with autobiographical memories of psychosis might be the ones that we need to maintain on antipsychotics. And those that have developed neural circuitries that are resilient to these autobiographical psychosis memories and they have integrated, may be okay to get them off down the road gradually. So, Michelle, you had some questions.
Thank you so much for these wonderful presentations. So exciting. Here in Massachusetts, we do a lot of work around trying to adopt good interventions in the real world. And I'm so interested, Dr. Nordhoff, in your data that your real world implementation seemed to perform even better than the implementation within the RCT, if I saw that correctly. And I wondered if you have any thoughts about why, and anything that we can learn here in our state that would be relevant related to that.
I must admit, we had expected the opposite. We had expected that when it was implemented as everyday life practice, that there would not be so much enthusiasm and that things would deteriorate to some degree. And also, we have seen that the caseload has increased. But what I think has happened is that the model has settled. And well, sometimes it's romanticized how things are in the beginning, and there's this phenomenon called Horton effect, where people are so excited that everything goes well. But what also happens in the beginning is that people are so enthusiastic, and then they start arguing about what is the best, and it takes a time to get things to work. And I think we have actually succeeded in creating a culture and some practices that are very well rooted, so that we can now implement it widely. And I think in a way where we have a high level of program fidelity. So I think that's why we see these positive results.
Thank you.
We have time for one more question, maybe.
I have a question. I put it in the chat, but I can say it out loud. So as I understand, Denmark has a significant population of Inuit people as a result of the colonization of Greenland and also like the natural diversity of the population of people who live in Denmark is something that I think should also be a consideration when doing the data analysis. So from the data that y'all collected and the demographics that you had available to you via your sampling methods, do the benefits of the specific model of early intervention within the study benefit Indigenous people and racialized people in equal measure to the white folks in them?
Yeah, I'm afraid the proportion of these population is rather small compared to the large majority. So I think we wouldn't be able to make analysis focusing specifically on some marginalized group. I wrote a comment to another question where we looked at what we have seen is that Opus is actually more effective the lower the functioning of the people. If they have more challenges, that's where we can create a difference, because some of the patients with a good prognosis, they can actually do with much less, I think. But I do realize that sometimes there are challenges, but there could also be there could be situations where we actually can collaborate very well with the people from, for instance, Muslim cultures where there's much, if the father says that they should take the medication, they do. So I think sometimes we have good collaborations with the parents about how to treat the young people. But I cannot answer your question regarding the Greenlandic population. We have some, but it's too small a sample.
Thank you, Merita. And I want to thank all the panelists for a wonderful, very insightful discussion. So that brings us to the end of this panel discussion, and we have an exciting presentation about the early intervention and interfacing with across different phases of the illness by Bob Heinsohn, one of our leaders in this field, and Margaret Geyer is going to introduce